Hello everyone, this is Mary Gregory with Medical Administrative Solutions, better known as Mass Coding. Welcome today to Code and Talk, Code and Speak. Today we're going to be continuing talking about preparing for the CCS, and also we're going to kind of work in marriage preparing to become an inpatient coder. In November, we will be sponsoring a mastering an inpatient coding workshop, and we like to encourage everyone that is thinking about becoming a inpatient coder. If you're thinking about doing CDI, this would be a class you may want to look into, investigate. So we'll talk a little bit more about that at the end of the video. Today, we're going to talk about the query process. What is a query process, you may say to me? Well, it's just asking a question to a healthcare provider. I don't have time to go into the history of how we got to where we are with this querying process. There's AHIMA has published two very good papers on managing an effective query process. That's going to be the basis of what we're going to look at today. In healthcare, in coding, in the coding world particularly, we always have to have documentation from a reputable source in order to code, in order to apply these guidelines. So AHIMA works in conjunction with CMS, which is the Center for Medicare and Medicaid Services. AHIMA stands for American Health Information Management. I've been in coding and healthcare for so long, we love talking in acronyms. So I have to periodically go back and explain what those acronyms are. Now, I won't be able to get into all the moving parts of a query process. There's a couple of different things I just want to, I want to key in on. Of course, like I said, AHIMA has published some great papers. I encourage you to go out and read them. The one we want to talk about today, because you will see some questions on the CCS that may need the correct answer may be to query. They also may give you some question about when would it be appropriate to query. So today we're going to talk about, under the query process, we're going to talk about documentation and coding. They say the primary purpose of the health record documentation is continuity of patient care. Or like I like to say, and you will have your own way of thinking about it, is how is this patient being treated? Can someone else come in? Can another physician come behind physician A? Physician B come in, they're going to take care of the patient. Can they take the information that's been documented by physician A and make great decisions about that patient health care? Great decision may mean they don't give them the wrong medication. They will not give them a medication that they may be allergic to. They will not treat them for a condition that physician A has ruled out. Or they may need to continue the treatment that physician A started. So documentation is all about continuity of care. It's all about someone picking up that healthcare record and being able to know what happened to that patient. We're in election time. I'm not really sure how long we keep these videos out. But we're in election time here in America, just in case you're listening to this internationally. And it's been a big, it's been a lot of talk lately about the candidates' health. And people want to know, people want them to release their medical records. So here we are, we have two people running for the President of the United States. And people want to know, are they healthy enough to be President of the United States? How bad would it be for us to elect a president of the United States and they die all of a sudden? Which I know that can happen. So people want to see their medical record so they can make a decision if this person appears sick based on their medical record. Do they have a lot of chronic conditions? Then that may affect how they vote. So I just want you to, that's how important this documentation is. Sometime in the coding world, because the documentation is also used to get reimbursement, to get the proper reimbursement, that sometimes we really forget what is the true reason for a medical record. The true reason for a medical record is to make sure that the patient is receiving the quality care that they should be receiving. Are we doing, as facilities, as physicians, are we doing what we're supposed to do? So today, we're going to be talking about documentation. Now, I am talking about documentation today from the standpoint of when we have a record to code. And this could be inpatient, outpatient, physician office. Is that documentation in that record sufficient for us to generate the correct code? Sometimes it is, sometimes it is not. When it is not, when that documentation is conflicting, when that documentation is confusing, then the coder, especially inpatient coders, and you'll see this on the CCS in some form of another, you're going to have to know, do I need to submit a query? Now, you can't become a query queen or a query king, meaning you're querying for everything. You have to know how to take the guidelines, take the documentation, and marry those two. So today we're going to talk about documentation and coding, and we're going to talk about when is it appropriate for us to generate a query. You cannot just ask a question about every little thing in the chart. You also cannot query the physician clinical ability. And so we have to be very careful with the querying. So today we're going to talk about, from the query process, 1, 2, 3, 4, 5, 6. These 6 things. When can we query? When is it appropriate to query? It is appropriate to query, number one, in a situation where you have clinical indicators of a diagnosis, but no documentation of the condition. Now, in the old days, like I said, I can't get into the history, but in the old days, a coder was not allowed to submit a query and ask a physician about a diagnosis that wasn't in the chart. So let's give you an example. Let's say our patient is coming in with a COPD exacerbation. And we notice that the patient, and this one can be a little tricky, COPD exacerbation. So the patient got some shortness of breath going on. They put them in ICU. Then the physician also document the patient got 3, 4 plus pitting edema. They do a chest X-ray, and the chest X-ray is showing some pulmonary edema around the heart. We are seeing where the physician is giving that patient IV Lasix. But that could be a diagnosis that clinically indicates some type of CHF, congestive heart failure. But the physician haven't said congestive heart failure. So now we have clinical indicators. We have treatment being given for a condition that the physician has not given us a diagnosis. If the clinical indicators and the treatment meets the definition and for congestive heart failure, systolic, diastolic, or a combination, we can ask the physician about that. And when you generate that query for that physician, you have to give them that information. You just can't generate a query and say, did this patient have systolic heart failure? No, you cannot do that. You're going to have to give them the clinical indicators. And a lot of times in the inpatient world, you have to tell the physician where you found that information. So I may document in my query, progress note, a 910, document pulmonary edema. Chest X-ray is consistent with pulmonary edema. IV Lasix given. Are you treating some form of congestive heart failure? and then you will give him or her all the options of that disease. You'll give them the options of acute. You'll give them the options of acute or chronic. Those are, and then you always have to have an option, unspecified or other or unknown. You got to have one of those options on every query. If you never give that physician the option of saying, I don't know, then you have a compliance issue. You have an inappropriate query. Let's move on to the next one. The next reason you may want to query is because you have clinical evidence of a higher degree of specificity or severity. So now my patient is coming in and my patient has a pneumonia diagnosis. However, the physician is documenting that the patient is aspirating. And you may go to the chest x-ray or CT of the chest, and it's saying that it has the appearance of maybe an aspiration pneumonia. And you're looking to see what type of antibiotics that's being given. They're giving vancomycin. They're giving a heavy duty. I like to call them third generation antibiotics. You see that. Now you may have a diagnosis that is very severe. It's a lot severer than the physician has documented. So it could be very appropriate to ask them that. Are you treating a bacterial pneumonia? Are you treating, and you want to give them options. You always have to give the physician more than one option. I could never send a query and say, are you treating aspiration pneumonia? You could not do that. Your query must give options. And so your option could be a bacterial pneumonia. Your options could be a aspiration pneumonia. Your options could be a community-acquired pneumonia, and of course an option of other options of uncertain, I don't know. You just got to give them those options where that physician have the opportunity to write a comment if they need to. They said other, or they can say unknown. So you want to give them those options. The next time you want to query is when you possibly have a cause and effect relationship between two conditions or an organism. Once again, your patient may come in with a pneumonia and your physician document. A lot of times physicians like to document healthcare associated pneumonia. In our coding world, that's not a very specific code for healthcare associated pneumonia. When you have a healthcare associated pneumonia, it simply means that that patient has pneumonia because they've been in contact with healthcare. And it's interesting, they say that contact could be a nurse or a doctor that work in healthcare, and now they go home and their child or their wife or their family get a pneumonia. It could be a healthcare pneumonia because they could have gotten it from the dad because they've been exposed, or from the mom if the mom is a doctor, if the mom is a nurse, if the dad is a nurse. And so they can come in with healthcare associated pneumonia. Healthcare associated pneumonia can be, and generally is due to some type of bacteria that has been picked up in the hospital. The most common could be staph, a staphylococcal bacteria. And so you as the coder, when you see healthcare associated pneumonia, you're going to look at your cultures to see if did the culture grow out anything. Did they grow out of staph? Did they grow out of strep? And when you see that, and once again, you got treatment that's geared towards that, it'll be very appropriate for you to ask, is there the relationship between the pneumonia and the bacteria that is growing in that culture? Another reason when you want to query is when you have an underlying cause when admitted with symptoms. You shouldn't be coding out an abdominal pain and it's due to the patient having acute diverticulitis. Yes, when the patient presented, they had abdominal pain, but now they have documented that the patient have acute diverticulitis. Maybe the physician is busy that day and they just write abdominal pain. But now you have an established diagnosis in there that could be responsible for that abdominal pain. And so anytime you have signs and symptoms, but you have documentation that a condition exists that may cause that sign and symptom, then you can clarify. Once again, this one here is a little bit like the clinical indicators. Only the treatment is documented without a diagnosis. So once again, you got a patient getting treatment. I mean, I'm just going to throw something out here really, really crazy. Supposing you see that your patient had an open reduction with an internal fixation device, and you don't have a diagnosis of fracture. You don't have a diagnosis of non-union of a bone. Why would they do that? So you cannot say, oh, I got an ORIF and I'm just going to code it, and you don't have a diagnosis? Now, so you wouldn't want to do that. Now, there may be times when you may have a diagnostic test and you may not have a diagnosis, because let's say the patient has come in, once again, maybe with abdominal pain, and they want to rule out diverticulitis. And they rule it out. So, you may have a CT that you're not going to have a diagnosis for. So you got to learn to balance things. And see, coders get paid to think. That's my mantra, and I will always believe in it. You just cannot say, well, I got a CT. I always have to have a diagnosis for the CT. You have to realize physicians do certain things to work patients up. So you're never going to have a diagnosis for every little thing that the physician does. But when you have a diagnosis that impact the patient care, then that diagnosis generally, or it may be a sign and symptoms, should be documented. So keep that in mind. That's why I say you got to learn to marry all this. You got to learn to marry signs and symptoms. You got to learn to marry all these diagnostic testing that may be done. You're not going to have a diagnosis for every diagnostic test, because some of them are done to establish a diagnosis, and when there's no diagnosis, you're not going to have one. So watch out for that. And of course, you can always query for POA. Was something present on a mission? Now, I'm a firm believer that you coders and people that want to be coders, one of the things you have to do is you got to learn how to do your research. And we got some POA guidelines at the very end of the official coding guidelines, and you need to know them. Did that patient have a sign and symptom at the time of admission? Once again, if your patient came in with abdominal pain, high WBC, and 2 days later they document diverticulitis, I don't need to ask the physician if diverticulitis was present. They had signs and symptoms that diverticulitis was present, so the POA would be a yes. You need to know the POA guidelines, because the POA guidelines said that at any time during the stay, the physician can document that something was present on admission. So you need to be aware of that. So, alrighty, that's our class for today. I don't want to keep you very long, but I did just want to give you some little clues about the query process. Now, there's more involved in it, but a lot of times when you take your CCS, those are the general types of questions that you kind of will see. Do you know when you can query? And so you got to know, I can query when clinical indicators are there of a diagnosis, but it's not documented. I can query for a higher specificity or severity of a diagnosis. I can query when there's documentation that there may be a cause and effect relationship between a condition or organism. I can query when I have an underlying cause, when my patient was admitted with symptoms and the physician forget and diagnose symptoms as my discharge diagnosis, or only the treatment is documented. If you are striving to become an inpatient coder, I'm telling you it's a shortage of inpatient coder. If you will pay the price, see, I believe in self-empowerment. There's going to time you're going to have to pay the price. Nobody else can pay it for you. If you're willing to pay that price to become an inpatient coder, I guarantee you, if you become good at it, you'll never look back. Your rewards would be tremendous. People just, when you're an inpatient coder, and don't get me wrong, outpatient coders are great too, and you get a lot of respect when you're outpatient coders, and you get a lot of respect when you're an inpatient coder. Inpatient coders, so many of them that I know, have used that to really grow their careers. They get into quality. They get into case management. They can get into CDI. They get into IT. It's just something about that inpatient that causes people to be able to move further in their careers if that is something they want to do. And it's probably because when you're an inpatient coder, you really have to have a lot of critical thinking skills. You have to learn how to marry all that documentation and come up with the right code. But I love it. You'll love it too. On that note, MAS is going to be sponsoring a Mastering Inpatient Coding class November the 17th and 18th, I believe, here in our beautiful Charlotte, North Carolina area. I am giving you a personal invitation to come and join us for that workshop. So if you're looking to be an inpatient coder and you're not sure what it looked like, what does that look like? Come and spend 2 days with us. And we're going to show you what it looked like. We're going to be talking about the definition of the principal diagnosis. See, that's key in inpatient coding. It's huge. And we got some guidelines that go along with that. 2 things present on a mission. Both of them are equally treated. What's the definition of equally treated? What do you mean 2 things are present on a mission? We're going to talk about that. We're going to talk about 2 conditions that interact with each other. And both of them are equally treated. Do I have to do the do to first? Let's talk about that. Let's see how we're going to handle that. We're going to talk about problematic diagnoses. You know, as an inpatient coder, I do want to warn you, if you don't have tough skin, if you're a crybaby, inpatient coding not for you. Now, in America, we don't like to hear stuff like that. But we want to say, oh, everybody can be an inpatient coder. Not everybody can be an inpatient coder. Because there are days that physician going to jump all over you. There are days when your coding manager is going to get on you. You are subject to so many audits. It's ridiculous as far as I'm concerned. But if you can have all that, if you got that mental toughness, you got the emotional toughness, inpatient coding is for you. So come and join us at our workshop. We're going to be talking about UHDDS guidelines. See, inpatient coders, they have to follow the guidelines. They got to know how to marry them to the documentation. And we're going to be talking about that. We are going to prepare you now to become an inpatient coder. If you're already an inpatient coder and you say, I just need to beef up on some things, come join us. Or you're a CDI specialist and you say, you know, I got this training several years ago or several months ago. I really didn't get a chance to understand it. Come, join us. I'm telling you, when you come to this Mastering Inpatient Coding 2-day workshop, I guarantee you, you will not leave the same. Look forward to seeing you in November. Don't forget to follow us on www.MAS Coding Solutions and www.ICD-10 Coding Connection. Actually, ICD-10, www.ICD-10codingconnection.com is where you're going to find all the information about mastering inpatient coding. Don't forget to tweet us if you like us. Tweet me. Send me a Facebook notification. LinkedIn. I'm on LinkedIn. We on all that social media. You know, I don't do too much with Instagram because I haven't time to be taking a lot of pictures. I'm busy. You know what happened? This is just a personal thing. I left Charlotte last week on Friday. Okay? I got back this Friday. And I thought about it this morning. I said, oh my God, I have not been in my own bed for 6 nights. I've been sleeping in bed that other people have slept in. So sometimes, you know, so I've been on the road a lot, but I like it. And you know, 2 of those days was in training. I got over 20 years of coding experience, and I'm always training. And that's one thing about being a coder, is a lifelong career. You're going to always be studying. Look forward to seeing you in November.